hemorrhoids. And so let's talk about a little bit about what this is and what we can do about it. Essentially, if you look at this graph here, this is the liver, your stomach, which is partially cut down, but we're really going to focus here on this big vein called the portal vein, and that separates into the iliac veins, which go into your legs. But you'll notice we're going to be focusing on, because of hemorrhoids, the anal area, and specifically these veins here that actually travel back up into the portal liver system here, and can become enlarged and cause pain if they're external. If they're internal, it'll feel like fullness, and they can actually protrude out the anus. It causes a lot of problems for a lot of people between the ages of 40 and 60 and pregnant women. So over here we have a picture of the rectum, and you'll see this line right here. It's called the dentate line, and this is what people that proctologists specialize in hemorrhoids, what they separate the lower from the upper rectum in an anatomical fashion. Now there's two kinds of hemorrhoids. We have the external hemorrhoids below this dentate line, and we have internal hemorrhoids that occur above this dentate line. External hemorrhoids are painful because we have a lot of nerves, and I'll show the next slide, feeding this area, and they're somatic, meaning they affect the body, so we have a lot of pain with that. Internal hemorrhoids are visceral nervous system, which is the organs, and we don't really feel our organs, so these tend to be less painful, but they can actually protrude out if grade 4s, can protrude out the rectum and cause problems that way. Here's another picture of, they're not really showing that dentate line, but it's somewhere in here, and we have an internal hemorrhoid that's developing right here from the rectal veins, the hemorrhoid veins, and an external that's developed, and this will be painful here. So let's talk a little bit about the nerve plexus real briefly that feeds this. So here's the rectum, and you can see the spinal cord. Now obviously the spinal segments are not shown, it's just showing a generic picture. But we have this somatic nerve here that goes all the way feeding the branches of the external and distal rectal area, and then we have visceral nerves here feeding the internal rectum that we can't technically feel, that come back here to the spinal canal so that the muscles can move and whatnot, so we can have a bowel movement. Now here's another picture of that dentate line we talked about. We have internal hemorrhoid, so these are dilated veins. They should not be that large, they should be small like this to return blood to the liver. And then we have one here that's actually protruded, so a grade 3 or 4 of 4 internal hemorrhoid, and then we have external hemorrhoids here where the veins have obviously are more normal here and have dilated into something that can be very painful. Now when we're talking about internal hemorrhoids, these ones coming from above that dentate line, they can prolapse. This is a picture of the rectum, and all this hemorrhoid here is internal, so it shouldn't be too painful, but they've actually gone completely out of the rectum. Now if you can reduce this with your finger, if you can push this back in, that's a grade 3 of 4, but some become so bad that you can't actually push that back in, and that's a grade 4 of 4 internal hemorrhoid, and we'll talk a little bit more about that on the next slide. So with the grading of internal hemorrhoids, we have grade 1, 2, 3, and 4, and like I had mentioned, the grade 3 can actually protrude out, but they're reducible, meaning you can push them back in and they stay in. Now grade 4, no matter what you try to do, you can't get this hemorrhoid back in. Now we're talking about the internal, not the external. So if you look here, these are the external hemorrhoid veins, and this is the internal hemorrhoid veins, and obviously we have developed basically a giant hemorrhoid here. What is done about grade 4 is surgery. So they can either go in here and put a band around this to cut off the blood supply, they can staple it and remove it, excise it surgically. All those things can be done by somebody who's a proctologist. If you have a grade 1, you may not even really know it, and grade 2 can kind of present with like rectal fullness, and because it's not actually out of the anal canal, unless you're straining, it'll pop out, but it'll go back in by itself. It's a little harder to see. In office, you would basically have to have your patient strain in order to see something like that while you're doing a rectal exam. Okay, so let's talk a little bit about what are the signs and symptoms. Well, typically hemorrhoids start to occur around 40 to 60. Pregnant women that are younger can develop them. There's a lot of pressure from the abdomen pressing on the rectum, those veins. And so if any weight gain there can make it worse, all that pressure coming down. If you have any type of, now this is a rare event, but a tumor in the pelvis can press down, uterine cancer, ovarian cancer, things like that. Prolonged sitting has been shown to increase hemorrhoids, as well as constipation because you strain, and all that rectal pressure tends to make those rectal veins swell up and create hemorrhoids. So straining, prolonged sitting, we need to avoid that. If you have to sit for work, you need to get up regularly to prevent increased sphincter pressures. They basically are saying increased sphincter pressure causes hemorrhoids. So sitting, there's a lot of pressure. The musculature around the connective tissue can't help strengthen the area when we sit too much. And so that's a problem. So there is some research showing the connective tissue that anchors those veins around the rectum essentially weakens and allows those veins to dilate and cause problems. Some signs of this, the most common is some bloody stool. You got to think about a vein in the rectal canal. A BM would scratch, open that up, cause some wiping, a little bloody wipe, things like that. If you have external hemorrhoids, these are very painful. So below that dentate line, this is actually an external hemorrhoid that has formed a clot, a thrombus in it. These are very painful. This is when people show up at the office to get treatment for an external hemorrhoid. Very uncomfortable. It is an external clot. And so essentially what we do about that is we basically numb it, incise it, squeeze the clot out, and leave it to heal. And we'll talk a little bit more about that in the next slide. Now, what occurs when you have these external hemorrhoids is it deforms the skin around the rectum and leaves, once these heal up, they leave skin tags, and they cosmetically don't look that great. And so people will sometimes have surgery just to remove that extra skin to make the rectal area look better. So that's something that people do. These are all conservative things that you can do. So you can get a prescription for lidocaine cream. It numbs it. You can place it right on the hemorrhoid and numb the area, especially the external hemorrhoids are very painful. You can use a little bit of hydrocortisone cream with the lidocaine or alone, but you don't want to use hydrocortisone on the skin for more than 7 days. It tends to thin the skin out and can make problems worse. It will reduce the inflammation and some of that pain if you just use it for a few days. Over-the-counter phenylephrine. Phenylephrine causes veins and arteries to constrict, so essentially the cream hopefully can kind of constrict some of that pressure. The other thing is, because there's a link with high sphincter, high rectal pressures, and extreme sphincter tone in people with hemorrhoids, warm sitz bath, you can use some Epsom salt, can help relax the sphincter muscles of the rectum and the anus to try to reduce some of that sphincter pressure. The other thing that people do is they use a little witch hazel after BMs to try to help constrict some of those veins, which is not a bad thing if you really suffer from that, is just get in the habit of using a little bit of witch hazel on a little pad, and just after you're done cleaning, wipe the area, the hemorrhoid area around the anus. The other thing is constipation is highly linked because it increases sphincter pressures leading to hemorrhoids. So getting enough fiber, you want to soften the stool. Fiber makes it soft, so that's important. If you have a lot of problems with hard stools and straining, Docusate is available over the counter. It's used constantly. We use it in the hospital with patients. It's a stool softener purely. It is not anything that causes more BMs. It just literally softens the stool. We know certain drug classes cause constipation, so you need to preemptively treat that if you suffer from hemorrhoids, especially opiates. Any antidepressant, anti-psych meds tend to cause constipation. A lot of people don't drink enough water, and so the recommendation is to drink 2 liters as your target minimum if you have hemorrhoids. Water helps soften the stool, so that reduces the straining. The other thing you have to really, for physical, is no straining. So if you have to have a BM, you need to relax, no pushing, no straining. That causes those sphincter pressures to increase so much that it can prolapse or cause the veins to hemorrhoid out and enlarge. And if you have to job that's prolonged sitting, it increases the pressure on the hemorrhoids, and getting up every 15 minutes, don't sit continuously, can help reduce that. Don't sit on the toilet longer than 10 minutes. Get up, move around. Sitting on the toilet has been linked to hemorrhoids, so we don't want to do that. So the patient I see in family practice comes in, if you look at this picture here, these are external hemorrhoids. They look like giant bumps around the anus. These are very tender and painful. And a lot of times when the pain is so bad, they'll show up within 48 hours in the family office because there's a clot in here. This vein has literally stagnated blood flow, and it clots and it causes tons of pain. So typically what I do is I'll come in and I'll numb this up with the lidocaine with the syringe right into the vein itself and around this. And then what I do is usually cut a little elliptical incision here and manually express the clot. The clot will come out. We don't sew it up. We just let the skin heal on its own. I put a 4x4 gauze on there, a little antibacterial ointment, and then just have the patient change it. Expressing it out allows it to bleed a little bit, which helps clean it out. Now, if you have internal hemorrhoids, which this is showing here in this picture, so what they can do is they can go in here, and because these are less painful, they can go in and actually wrap a rubber band around this, essentially blocking blood flow to these cells. You can see it right here is actually a great picture, and it will just fall off naturally. That's one option. Proctologists also can go in, cut and staple. They can incise. There's a couple different ways that they handle this. That's a referral-based, non-family practice treatment, but it does give people that have prolapsed internal hemorrhoids are coming out of the anus and they can't treat them an option. The banding is a great option for people on blood thinners also, because if you're cutting hemorrhoids, they're going to bleed a lot if you're on blood thinners for whatever reason. And that's all I have. Thank you very much. Take care.